It's such a pleasure to be here. Good to see old buddies like Sudhir. We go back a long ways. Thanks for inviting me to present this work here. Okay, so this is off the beaten track, not just generally as a marketing research paper, but also in relation to the previous talks you heard in this session. So what we are doing in this work is addressing a crisis that's been ongoing for about a couple of decades, if not longer, in this country. So this is joint work with Annie, who's one of my PhD students at Olin. In fact, she's the driver of this work. This is her baby, so if there are any questions about the actual analysis, you can direct them to her. Okay, so the inspiration for this work stems from what is called the Olin Brookings Commission, which was set up at the behest of the Bellwether Foundation, which gave us a grant of money to investigate this. So the problem was that there is a lot of focus on addressing the opioid epidemic at the bottom of the distribution channel. By that I mean investigating physician prescriptions, looking at transactions at retail, such as CVS and Walgreens and the like, to see where wrong behavior takes place, either by way of dispensing prescriptions that should not be, or by way of fulfilling prescriptions that should not be. But we took a somewhat different approach to this. So we went up the distribution channel and said, hey, can we try to address this problem at the source before waiting all the way to looking at what is happening at retail? So we wanted to address some blind spots in terms of what can drug distributors do to solve this problem. So I'll explain more as we go along. So the approach we take here is to use data science or AI to address this problem. So can we preemptively prevent shipments of opioid drugs to communities where they should not be landing in such large numbers, right? So that is the big picture problem. So let me show you the database that we are actually using. This is called ARCOS. It's publicly available. You can download it from the Washington Post website if you like. So this tracks the movement of every pain pill or every opioid drug that's been sold in the US as a census. This is not even a sample, over a period of actually 12 years. So we end up using that 6-year period that is shown in this slide. But every movement in that distribution channel is actually part of this database. Now, how did this database come to be? It was released as dictated by court order at the initiative of HD Media and the Washington Post. So there was a lot of litigation going on in this space, as many of you would know. So that's how this data was released to the public. So here, just to give you a sense, I'm showing you transactions on the left graphic with actual overdose deaths on the right graphic to kind of set the stage that the heavy velocity of transactions are clearly, even visually correlated with, the problem in terms of overdose deaths. So here is how the distribution channel arrangement looks in this space. So going from left to right, we have the product moving from manufacturer through the drug distributor. There are 3 large ones in this country that control most of the distribution. Then through retail to the pain patient. Of course, there is a physician involved, so the prescriber is an important part of this channel arrangement. Now, as I said before, this ARCOS database goes from manufacturer to distributor to retailer and stops there. What we do not observe is what's happening at retail. What we also do not observe are the prescriptions themselves. So therefore, we are going to look at the upstream of this channel, as I said, and look at what can preemptively be done by analysis of that data. Now, in that effort, we are going to focus on movement from distributor to retailer. We are not going to use the data from drug manufacturer to distributor. Okay, now why is that? Well, because drug distributors like McKesson and AmerisourceBergen have systems in place where they want to or would like to monitor products that are being shipped to retailers around the country, which is why we took a stab at that part of the distribution channel. Okay, so in working with ARCO's data, we had to make a lot of judgment calls in terms of how to winnow the data to be right for analysis. So the first thing we did was recognize that every transaction is associated with a distributor-retailer pair, and that retailer is the buyer in our analysis, can be profiled succinctly in terms of that right box. So we have the DEA, the Drug Enforcement Administration registrant ID associated with each buyer, and along with that, we could classify a buyer into, hey, is this buyer a retail pharmacy? If so, is that an independent pharmacy or a chain pharmacy? Or is it neither? Is it a hospital? Is it a practitioner? And so on. And furthermore, we have the physical address of that retailer, plus the longitude of transactions over that 6-year period. Everything that they did in terms of ordering opioid drugs. The data is a lot richer as shown in the left graphic, but we are going to winnow it down to a set of variables that I'll set up. The second thing we did was recognize that there are a total of 9,000 plus SKUs in this space of pain pills. But if you looked at these opioid products, you would soon recognize that they are just different combinations of APIs or active pharmaceutical ingredients. So if you look at the space of APIs, we are really talking about different combinations of 170 different things that go into this 9,000 SKUs. If you went down one level, you would then recognize that there are only so many molecules to go around in constituting these APIs. How many? 14. So in the space of drug compounds, this is really a 14-dimensional problem. Every opioid purchase is some combination of these molecules. Now, what molecules are we talking about? The main ones are shown on the right. So in our data set, the top 4, if you will, are hydrocodone, oxycodone, fentanyl, and morphine. So they account for upwards of 80% share of transactions in opioids. Of course, our analysis is going to exploit the fact that at the end of the day, the consumer is being dispensed some combinations of those molecules. We are not going to get rid of any data. All transactions will be part of the analysis, but we'll look at the purchase at the degree of the drug compound. Although I show you 7 of them or 8 on this, we're going to use all 14 molecules, of course. We are not leaving any data behind. Again, any clarification questions, feel free to jump in right now. Don't keep it to the end. The other questions I'll take at the end. Okay, the third thing we did was we asked, how do we make these transactions comparable to each other? So for that, we made use of an industry standard called MME, which stands for morphine milligram equivalents. So even if a retailer is placing order for hydrocodone, that can be translated into how many equivalents of morphine is that, right? So morphine serves as the industry standard in this space. So then each purchase can really be thought of as purchase of MMEs. So for that, there is a formal formula given by the DEA, which we use. Then the fourth thing we did was ask, what are we really trying to do here? We are trying to identify suspicious retail buying. Now, what does that even mean? So this database has a total of 277,000, roughly, buyers across the country, retail buyers. And they made upwards of 400 million transactions in that 6-year period. So among these, we identified those who are actually convicted of bad behavior or ordering quantities that they were not supposed to, given the local demand for pain pills. And these were 188. So this is a classic needle in a haystack problem. There are 188 bad actors in a sea of 277,000 actors. So those of us who do predictive modeling or supervised learning would see there's heavy imbalance in this data if you're trying to ask what distinguishes these 188 bad actors from the ocean of good actors that are out there. So here are those 188 bad actors shown geographically. And you would notice that's the Rust Belt and that's Appalachia, which suffered this problem enormously over that period. So we do have a good number of them clustered in those parts of the country. And then if you looked at the legends, you would see that most of the convicted buyers are practitioners, as we also know from stories on 60 Minutes and PBS and so on. Now, practitioners in turn can be large or medium, and pharmacies constitute the rest, and a majority of the convicted pharmacies are not the likes of CVS and Walgreens. They are independent mom and pop pharmacies around the country. So it's pretty much two buckets. We are talking practitioners and pharmacies of the independent kind. And the last thing we did was we said, well, if you want to explain these needles as differing from the rest of the haystack, then we have to understand what legitimate buying behavior in fact is. So for that, from the population of buyers, we randomly sampled about 50,000. And this would be the pool of legitimate buyers in relation to whom we will explain the 188 needles. So then we did some exploratory analysis. We said what distinguishes the legitimate buyers from these convicted buyers. So there are vastly more transactions among the 50,000 legitimate buyers compared to the 188 convicted. So here is what we found. We said, in terms of the profile, longitudinally, in terms of what they are doing, the legitimate buyers and convicted buyers are day and night different. They are very different from each other. And second, the legitimate buyers are fairly homogeneous. Regardless of whether you're a practitioner or a hospital, there is a lot of similarity in longitudinal buying behavior. Not so with the convicted. So convicted buyers are vastly different from each other as well. So bad behavior comes in various shades. So here are again some initial statistics on what distinguishes the convicted from the others. Again, night and day different in terms of what they are doing by way of how much opioid they are buying. So the first one shows on a per transaction basis about 2,000% more being purchased by the convicted. Then we said maybe the convicted buy in volume. They have longer interpurchase times. What if we control for that? So the second graphic shows you MME on a per day basis, regardless of their frequency of buying. If anything, the difference gets even more exaggerated. And the third one shows you, well, what if we control for the amount of pain in that county? So for that, we used the number of elderly people from the census. Ostensibly, it's the elderly who require opioids more. So that's a rough kind of way of correcting for that. And then the difference never goes away, right? It's always there. So clearly, there is something that's staring us in the face, which shouldn't surprise us because these people were, after all, convicted. So these are the ones the law enforcement had an easy time of detecting and hauling to court. Okay, so now then we proceeded to the next step of actually trying to analyze the data in a more disciplined manner. So we said, what if we summarized each buyer's longitudinal buying on 40 dimensions? So we created 40 input variables, some of which are shown here in bucket form. And all of them are variations of that MME theme. How much MME are they buying on a per day basis, on a per elderly person in the county basis, and so on. And some of them are about the number of distributors they are sourcing from. Even though there are 3 big ones, there are about 100 different wholesalers across the country. There are some retailers who buy from the same distributor every time. There are some who source from 100 different distributors. So there are some variables speaking to that, the concentration of distributors in their sourcing. And there are some about how concentrated the buying of these drug compounds is. Are they primarily buying hydrocodone? Is it, spaced across molecules and so on? And then, given this needle in a haystack aspect to the data, we approached the analysis in anomaly detection fashion. So we thought of these 188 convicted buyers as anomalies, and then said, can we use an anomaly detection algorithm to understand what they are doing differently than the regular buyers? So that is the machine learning technology that underlay our analysis. So remember, that's how many retail buyers are in total in our course, and we have randomly selected about 50,000 of them, call them legitimate, and we split them in usual fashion into those three buckets: training, validation, and test. And here, for anomaly detection, we do something that's very different from what supervised learning dictates. The training sample doesn't have any convicted buyers in it. It has only legitimate buyers. The 188 convicted buyers in equal measure are thrown into validation and test, 50-50. So the 94 of them self-selected, or we selected them to go into validation. So let me cut to the chase and show you the punchline. So these were the two accuracy metrics after we kind of trained our anomaly detection algorithm and vindicated the algorithm not just on validation, but on the test itself, right, which is a stricter test of how well our algorithm is doing. So I'll take you to the second measure first. We got a precision of 100%, which means what? If the algorithm says buyer beware, it's 100% likely to be right. But the recall commensurately was low. It was close to a coin toss, which is about 50% of bad actors could be correctly caught by the algorithm. So that was the recall or sensitivity. And the mean of these two is what is called F1 score, the harmonic mean, which turned out to be about 0.6. So this is the full confusion matrix on the test set. So what you should notice is we have completely eliminated false positives. So that is why the precision is as high as it is. And in American jurisprudence, we always err on the side of caution. We don't want to take somebody to court unless it's warranted. So that is why the skew in precision at the cost of recall. And then we did something. We said, well, is this F1 score as high as it possibly can be? So then we redid the analysis, this time focusing only on the retail pharmacies. So can we make the anomaly detector work better if we try to only explain what makes bad actors among retail pharmacies? And sure enough, improvement came in order of magnitude. So this is the confusion matrix focusing just on retail pharmacies. And what do you see here? You don't need to pay a price in terms of one type of error versus the other. We get 100% recall with retail pharmacies. So it seems like retail pharmacy bad behavior is predictable as long as we, again, on an ongoing basis, track their longitude of buying. And the red flag can show up for the DEA in real time if bad behavior occurs. So this is just a discipline comparison to various algorithms in the computer science literature. I didn't get into the technical aspects of our modeling, but let me just say the following. Our anomaly detector is something we developed. We have named it the density-based disjunctive gamma-beta algorithm. That's a mouthful. Happy to talk to you offline about it. But that's something we have built from scratch. Now, why is that? Because we tested the whole slew of algorithms in the computer science literature. None of them came even close to matching what our algorithm did. We mixed and matched various good features of different algorithms and put some original thinking into it as well, the disjunctive part, which none of the existing algorithms has. And some of you who have followed this research literature might identify something called isolation forest. That's a very popular algorithm, didn't do very well in our application at all. So this is the full comparison table, and that's the comparison table just for retail pharmacies, right? Regardless, our algorithm outperformed everything else. Okay, now which are the variables that were primarily responsible for the predictive accuracy of the algorithm? These four. So we have something called an estimated density threshold. I won't get into that. But here are the 4 variables that are doing most of the heavy lifting. It's the median MME being bought per transaction, the median MME scaled on a per day basis, per pain patient basis, the share of purchase that is oxycodone. So this was the period where Purdue Pharma was really coming to the fore, so that shouldn't surprise us in hindsight. And last, number of unique distributors. So bad actors are sourcing from many, many distributors. They're trying to hide bad behavior by sourcing from many suppliers. And then we did the following. So we went to data that has not been used in the analysis and said, can we now identify or cherry pick bad actors who have not been swooped down on yet? So we identified the top 25 in terms of the predicted probability of bad behavior. And here I show in blue some summary statistics in relation to what in our sample are actual convicted buyers versus legitimate buyers. And for those 4 variables that I just showed you. And you can see that at least for one of them, the top right, if anything in terms of median MME scaled on a per day per elder patient basis, the people we are picking on are egregiously worse than even the convicted buyers in our validation and test set. So therefore, the DEA might have value at working with us. We are in conversations with them to see if they can institute a third party to start implementing this algorithm. And here are the 25 buyers that I showed you individually across the country. And again, a lot of them are falling into Appalachia. Now, in terms of the impact we hope to have with our work, let me skip this. We are hoping to have the DEA, kind of use this kind of approach. Use our anomaly detector to have real-time alerts popping up when action needs to be taken. And the good news is intelligence is anticipatory or preemptive so that they can then prioritize, their action plan. So what do I mean by this? We hope to, give them a dashboard like this. So the engine is working in the back, analyzing real-time transactions as they are coming in. ARCOS would be the database that informs this. And you can highlight the high deviation buyers in red, and these are made up numbers, but this is stuff that can actually be implemented with our analysis. And moderately risky people are shown in yellow. The ones who appear to be all hunky-dory are in green. And the buyers are actually shown on the geography in the top left. If you come to the bottom left, the retail buyers are rank ordered in terms of the predicted probability of being bad. And in the top right, they are summarized in terms of the type of retailers they are. And in the bottom right, you have a search functionality where you can look beyond what is being shown for those buyers and say, can you zoom in on this part of the country or this type of combination of retailer and geography to get a better sense as law enforcement. In fact, there's a little bit of animation here in terms of how to use this search functionality. And this zooms in even more. If you want to look at a specific buyer and understand, what is it that makes this buyer suspicious, the buyer's profile is given on the left, and then you've got those dials showing, which of those variables are actually currently showing up as bad and tagging them as anomalies. And the entire longitude of buying behavior is shown on the right. This is an actual real buyer in ARCOS. So this is just for proof of concept that I'm showing this dashboard. So this is where we are. Would love to take questions and talk about the technical part of the project as needed. Thank you.
Thank you for your presentation. It's really really, really good. Can I just ask, if we are using real-time data, given your predictive model, how much data points does the DA need now to actually capture some of the behavior? Would you say it's a full year, 2 years? Because you're working with massive data sets over like a 6-year or 12-year period.
Yeah, so the DEA is very analytics unsavvy right now, right? They are thirsting for help, outside help, in assisting with the problem. So they have no strict demands on how much data we should use, at what granularity, and so on. It's our call to make, as long as the third-party clearinghouse is set up with academics' help, the way we are, in fact, talking to them. But that said, right now the problem has shifted to fentanyl, as you know. Right? We are in a different world now. And that not just legal fentanyl, but street fentanyl. But that aside, is this problem in this form gone? No, not at all. This is still one important component in this. So it's our judgment call to make. What is that rolling window of data that would be right? So we don't want to go back 6 years. We want to work with current data. So you want the data to be perhaps not more than 12 months. But the data is growing in real time. The ARCOS data is something that is available in real time.
Yep.
So therefore, we can use maybe 12 months of data. And how many red flags go up depends on their resources, available resources. On a weekly basis, do they have enough officers to swoop down on 2,500 retailers around the country? Probably not. 25 for sure. Now, what that magic number is will come out of those conversations. But the technology will let us rank order all the retailers in real time.
Very good. Thank you.
Yeah.
Have you thought of approaching the various entities that they may want to self-police, like if it's a CVS or Walgreens, that type of thing, they may want to monitor their own franchises for bad behavior?
Yeah, so the pharmacies are part of what is called the PD, there is a program, PDMP program, which is about self-policing, self-disciplining, and a lot of pharmacies are not really abiding by state laws on that. That's a separate problem from what we are addressing here. So what we are trying to do is letting McKesson, AmerisourceBergen, and Cardinal Health, the three big wholesalers, they have copped off billions of dollars to the Justice Department over the past decade for not policing this right. So at least we have a system now where they can preemptively say, well, this order looks very suspicious. Before we fulfill it, let's escalate it and send it to the DEA. And only if they approve are we going to fulfill this order. So that this is capable of help. And they are very interested. They don't want to continue paying these litigation costs moving down the road.
Thank you.
Thank you.